Good afternoon. Thank you for joining us for the Ask the Radiologist webinar series. Before we get started, I'm going to share some housekeeping items for today's webinar. Everyone on the call will remain muted for the duration of the webinar. At the end of the webinar, we will open the floor for live Q&A. We encourage you to ask questions, and you can submit your questions at any time using the chat box feature in the Zoom platform. If you would like to ask your question live, simply click on the Raise Your Hand button and we will unmute you during the Q&A portion. For today's webinar on varicose veins, we are joined by Dr. Antonacci. We also have your physician liaison, Travis Roseborough, on the phone. If you have any needs regarding patient education, referral forms, or other materials, Travis can stop by for a visit at your practice. Dr. Vittorio Antonacci is a board-certified vascular and interventional radiologist at Charlotte Radiology, where he is a partner and serves as the medical director for the Vein and Vascular Centers. He also specializes in venous and lymphatic medicine. I'm now going to pass it over to Dr. Antonacci to begin the presentation.
Hello to everyone and good afternoon. Varicose veins has been part of my practice now for over 20 years. And I think one of the most interesting patients we get in the office are patients that come in that externally on the surface on physical exam don't have a whole lot going on, that's noteworthy. But then when we do the ultrasound, we just see how much insufficiency and reflux there is and how much that contributes to the symptoms that they're having. So today we'll be looking at varicose veins from it being more than just a cosmetic problem. And we'll review some of the more significant complications, look at some pictures of patients with ulcers and swelling and all of that. And I do have a time at the end where we go over some of the treatment strategies we have and how they're different from what has gone on historically. We have a lot of slides. Hopefully I'll get through everything, but save your questions at the end. I'll be happy to go over any questions that come up along the way. We'll get started with a little bit of a review of varicose veins. So varicose veins are abnormally enlarged, dilated veins that you'll see in the lower extremities predominantly, and mostly because of gravity. And in the past, we've thought it was a defect in the valves. It's actually a defect in the vein wall itself that leads to the valves becoming dilated. And over time, the blood that should be heading back up towards the heart winds up pooling in these veins and distending these veins. And over time, these veins get more and more dilated, the branches get more dilated, and then it leads to more of the pathophysiology that we see in patients presenting with swelling and ulcers, where you have all this fluid that builds up in your lower extremities, and it leads to a cascade of problems, and the longer they have the insufficiency. So we talk about varicose veins as, predominantly being in the legs or feet, but you can see them in other parts of the body, and they can be pretty significant. So when we have patients with portal hypertension, they have varicosities in the stomach or in the lower esophagus. Hemorrhoids are basically varicosities in the rectum. And varicoceles are what we see in some men with that we'll see on ultrasound, and they're really just varicosities in the scrotum. So for different reasons and different tendencies in terms of pressure transmission in these veins, you can get distension, and they can lead to problems. In the case of portal hypertension, you're looking at bleeding, which can be pretty significant. And in the case of varicoceles, you can get more issues with just pain, discomfort, and some association with infertility. In many patients, veins, even though they're dilated, don't cause symptoms, or at least symptoms that they recognize. Because it takes a while for these veins to usually progress, most people adapt, and they'll tell you that, well, I'm not really getting pain. Most people thinking pain has to be severe or something that really is very significant. But over time, these veins can cause tiredness, can cause issues with exercise tolerance. And because it happens slowly, most people just adapt and don't recognize it. In many people, it's a problem of appearance, and they'll come in just because they don't like the way their legs look. And then when we do the ultrasound, a lot of times we'll uncover more significant underlying issues. But in many people, they'll present with discomfort. Some patients present with severe pain, burning. And in some cases, these do result in more significant medical problems. When we have patients that come in with ulcerations, these can be pretty debilitating. So when we look at the varicose veins themselves, the size alone doesn't indicate how bad the underlying insufficiency is. The size can depend a little bit on the ambient temperature, hormonal factors in terms of timing in pregnancy or during the normal menstrual cycle. And in some very thin patients, you'll see normal veins that look somewhat varicose. And on the other end of the spectrum, we see our obese patients where they have tremendous venous insufficiency leading to even lymphedema when it's been there long term. And you don't really have any varicose veins you see at the skin surface at all. When we're classifying these veins, we classify varicose veins based on where they are and their size. So truncal veins are ones that are involving the big superficial trunks, like the great saphenous vein or the short saphenous vein. Reticular veins are a little bit smaller. They don't necessarily have to be in the distribution of the greater or lesser saphenous vein. Sometimes it can be on the lateral part. These usually do connect back eventually to the truncal veins, but are not necessarily in that distribution. And then the telangiectasias, which we refer to as spider veins, and they can be linear or more arborizing, so they can present with different patterns. So most of these varicose veins are primary. They're just a result of the vein insufficiency leading to the veins increasing over time. But we do have patients that present with either deep vein thrombosis or occlusion, and not infrequently, probably every other week or at least once a month, we'll get patients that have not quite occlusion, but do have obstruction. And you've heard of May-Thurner syndrome, where you have compression of the iliac vein. We actually do see that at least on a monthly basis. So that is real. So when patients come in predominantly with left-sided varicosities or swelling, we'll often send them for a CT scan to evaluate the status of the pelvic veins, which can lead to distension of the superficial veins as well. We've seen pelvic tumors, sometimes post-traumatic AV fistula can pressurize the veins and they'll look varicose, but instead of just being our simple pressure type insufficiency, they're related to that underlying AV fistula with increased flow. So varicose veins and venous reflux. Blood pools in the veins causes these veins to bulge and swell. And over time, it just continues to progress. When they actually look at the basic science, the underlying issues, there's several enzymes that have found to play a role. And sometimes there's elevated elastase and other enzymes that they found when they actually look at the veins themselves. But really, it's really comes down to more of an anatomic issue. So when you look at the deep veins in the legs, all of the deep veins are surrounded by muscle and they're supported. The superficial veins are unsupported, usually running in some fascia that may or may be complete in some patients, incomplete in others. Sometimes it comes really right under the skin surface. So the anatomic part of this, with gravity and with blood pooling, and then you add in all of the other predisposing factors, just is really what leads to this progression in the lower extremities. It's the anatomy, it's the course of the veins. You add in the underlying, basic medical science, the pathophysiology. But gravity just over time really does play a significant role, and you tend to see an acceleration the more significant the varicosities, the more significant the distension in the lower leg. Here's just a diagram of the anatomy. The saphenofemoral junction is a lot more complex than people think. Most people think there's the saphenous vein and the common femoral vein, the superficial femoral vein, which we call the femoral vein now. But there are all of these pelvic veins that drain as well into that junction. And in the past, when they used to do surgery, they would tie all of these off, which would lead to abnormal obstruction of the abdominal and pelvic drainage. So people would get neovascularity and new veins up in the groin. So some of the new techniques that we'll describe later really address the saphenous vein, and we can very elegantly treat the saphenous vein below these pelvic veins and just leave that other drainage intact. On the calf side of things, you have the small vein. That usually leads into the popliteal vein. In 30 or 40% of patients, there's variation where you can see continuation into the vein of Giacomini and leading back up towards the upper thigh. So all of this really becomes very easy once you put ultrasound on the patient. So why is this all important? Because the incidence of varicose veins and venous insufficiency and their complications is pretty high. In males, you'll see 15% of males over 18 and 30% of women over 18 will have at least mild to moderate venous insufficiency. And by age 50, 50% of the patients you'll see in your office will have moderate vein insufficiency, which meets the criteria for being treated. The youngest patient we've treated in the office has been 12 years old. So some of our younger athletes start working out, lifting weights. This particular patient was a football player, and we had varicose veins that came up in the calf region that we had to deal with. So we'll see that end of the spectrum. With our older patients, we'll tend to see more significant complications like we'll see in the slides ahead, like bleeding or ulcers. But overall, we have 20 million adults or more with varicose veins or chronic venous insufficiency. So that's a significant part of the population that is dealing with this. And unlike artery disease, with vein disease, you have otherwise healthy people that come in presenting with sometimes fairly advanced vein disease. So there is definitely genetic predisposition, family history of varicose veins present in at least 15% of all cases. In practice, we see that usually more than 50% of patients will have at least one of their parents or grandparents that have had varicosity. So that's important when you're getting history. Increasing age, we talked about acceleration of varicosities as patients get older, the effects of gravity over time, gender related to pregnancy, and also just the hormones, estrogen and progesterone ratios that affect the blood vessels. So on a monthly basis, that can lead to a difference in the desensibility of the veins and can cause to some more progression in women than men. So obesity is really a significant issue with veins. The more obese patients are, the higher their right-sided heart pressures tend to be, which is transmitted to all of their veins. And that increased pressure will accelerate that weakening. There actually was an article that came out, a paper at the end of last year that had stated that patients over a BMI of 45 are particularly a problem, and you might need to consider weight reduction before trying to go ahead with treating, because those patients didn't do as well in their treatment plan. So you may get a note back from us that during the patient's conservative therapy trial, before insurance approves them, we might ask for help in trying to get them into a weight loss program. So over the course of 3 to 4 months, we can improve their success with the treatments. And pregnancy. So we talked about the hormonal effects, but there's also that pressure effect from the fetus on the pelvic and leg veins that will tend to worsen varicose veins, or maybe the inciting event where patients first notice their vein disease. Prolonged sitting and prolonged standing is both bad. So prolonged standing just weakens the wall of veins from that constant pressure, and the prolonged sitting can aggravate some of these veins because of just the pressure, mechanical pressure effect at the groin. Any trauma or any phlebitis that happens then is another predisposition to these veins progressively dilating. So symptoms. Patients will present, these are the more typical symptoms: pain, leg heaviness, aching, tenderness to palpation along the course of the vein. I've had itching, burning that sometimes you don't necessarily associate with veins, but in many patients is an issue. Some of the less common things you think about, night cramps. So patients will come in not infrequently with night cramps affecting their sleep, even on a nightly basis. And some of our patients have had this going on for years, and they've tried different types of supplements and whatnot to try to improve that with some effect. But what we see is in about 80 to 85% of the patients we treat, when they're done with the treatment plan, they're in 80 to 85% of those patients, their cramps are gone and they're sleeping through the night. So if you do have patients with significant issues with cramping that's not being relieved by supplements, calcium, magnesium, and some of the other different treatments, then it would be worth evaluating for underlying venous insufficiency. With restless legs, we see about a 50% response in our patients. A lot of times it's the patients who have that jerky type movement when they're going to sleep. That seems to settle down in a good percentage of patients. But in at least 50% of our patients, we'll see either a decrease in restless leg to the point where they're not needing medication, or they're able to decrease the amount of medications they're on for their restless leg symptomatology. Exercise intolerance is an important one. I think we talked about obesity, and part of a weight loss regimen is obviously exercise. But when you have patients who've been through a pregnancy or are obese and can't tolerate a whole lot of exercise, it's this downward spiral. They're trying to exercise, but the exercise itself distends the veins more, especially if you're not wearing compression stockings. So the increased distension causes fatigue and causes tiredness, and they don't want to exercise. So they start avoiding exercise and put on more weight. And so if you can break that cycle and you can treat the venous insufficiency, and the easiest way is just compression stockings. If they can tolerate exercise a little bit more with that, then you kind of reverse the process. If they can lose some of the weight, the venous pressures decrease and they can exercise more. So it's not infrequent that I get postcards from patients saying, I've lost 40 pounds or 30 pounds and really appreciate the help that getting my legs back to normal or close to normal had in my life. So edema is one of the more important findings. So by the time patients get swelling, they've had more long-standing vein disease. And actually used to be thought that, Starling's law, some of the fluid that leaks out into the interstitium gets absorbed in lymphatics, and that accounts for 10 or 20% of the resorption. In more recent years, they found that Starling's law that we learned back in medical school was actually not quite correct. It's up to 50% of that edema is relieved by the lymphatics or drained by the lymphatics. So when you get chronic vein swelling, over time, this leads to distension and overloading of the lymphatics. So patients wind up with veno-lymphatic edema. And the longer they've had edema, the harder it is for it to get back to normal. And so when you start having patients with swelling, it's very easy to have that evaluated to see if there is underlying superficial vein disease, or if there is deep venous insufficiency or something else that might require treatment before it progresses on to more advanced swelling. And skin changes, it used to be called the Wachovia tournament. I haven't been there in a while, but I used to walk that sometimes, and I think I could have handed out cards to half of the people walking in shorts, because the skin changes when you treat vein disease, you get familiar with it, you can really recognize them from 20, 30 yards away. And one of the most significant skin changes we see that is overlooked is hair loss. So our male patients will present with hair loss up to their knee, and they'll think it's from their socks rubbing over the years. And after we treat their vein disease, they'll actually have some hair regrowth in their lower legs. So skin changes, even things as simple as hair loss, unexplained hair loss in the lower leg, that could be a sign of vein disease. And then you get to some of the issues caused by the increased pressure and resultant hypoxia of the skin, where you get pigmentation and swelling, pigmentation and erythema, and we'll go over that in more detail here in just a little bit. So here are the complications that we see from vein disease. Edema being, one of the significant ones we talked about. Thrombophlebitis, so the stagnant blood. Sometimes you'll get a little bit of a clot, thrombus that leads to more inflammation. The pigmentation, the inflammation causing dermatitis, inflammation of the skin. Lipodermatosclerosis, which is just scarring the fat and skin that happens from the long-standing inflammation. And then we have ulcerations. And when I used to give these talks 20 years ago, sometimes we get patients that really didn't appreciate vein disease at all and would say, well, it's just because they're, it's more procedures and whatnot. And I don't think they understood the fact that we do have some of our elderly patients that have significant hemorrhage from varicose veins. Probably once every other week, we have a patient comes in with an episode of hemorrhage. Usually they wind up in urgent care or the emergency room, and they'll get a purse string suture placed and just temporize it, but it's not being treated. Now, if this happens at night, it can lead even to death. And there are some trauma articles out there which document that. So let's start out with thrombophlebitis. So inflammation of the vein wall caused by small blood clot. You've probably all seen this: redness, pain, swelling, warm to touch, usually along the course of a vein. And here we have it medially. Here's just a little cartoon showing the clot, and then depicted in a vein. So the importance of this is that associated with superficial thrombophlebitis, you can have deep vein thrombosis, which is why everybody gets deep vein ultrasounds. The corollary of that is that once the deep vein ultrasound is done and shows that's negative, the superficial vein part of it needs to be addressed as well. And I think, unfortunately, once we check off the box that says no DVT, we'll just treat the patients, with some local remedies and elevation and NSAIDs, and they're not referred for treatment. So while all patients with superficial thrombophlebitis should have ultrasound scanning, once that acute episode resolves, they do need to be evaluated for underlying superficial venous insufficiency. So we talked about edema resulting from the fluid and plasma collecting in the tissues. And here we kind of have the whole cascade of what happens in chronic venous insufficiency. But swelling, it can be pretty significant where it's one side and the other side is normal. And in those patients here, specifically on the left side, is the ones we refer for CAT scan to look for, or CT venogram more specifically, to look for compression. We have the pigmentation that I was talking about. This you can see from across the room. You start getting these brownish areas of pigmentation. There's just hemosiderin deposit from previous episodes of thrombophlebitis and the red blood cells rupturing. You can get red, wet, scaly skin from the inflammatory process that's going on in these veins. So when you have unexplained venous dermatitis, here we have a combination of dermatitis and the lipodermatosclerosis. You can see the caliber change here, the skin thickening. Here we have more of that scaly appearance. As we get into lipodermatosclerosis, this is a warning sign. It really, when you see this, the patient really needs to be evaluated for treatment, because the only thing that happens really after lipodermatosclerosis, if this isn't checked, if they get a little bruise or a little ulceration or a little minor trauma, that then becomes an ulcer that then we have to address. And in all these cases, you can see the ulceration, but the lipodermatosclerosis around it should have been a warning sign where it brought them to treatment earlier than they might, or earlier than they did with the ulceration. So why is ulceration important? Well, 1 to 2% of the general population are at risk because of some of the underlying insufficiency and some of the things we discussed, like lipodermatosclerosis. And most of these, or at least half of them, will have reflux in the superficial venous system. That we can fix. You have a combined reflux in superficial and deep in a percentage there, and only a smaller percentage is it just the deep. So in most of these patients, they can have either all of their underlying cause for their ulcerations treated, or at least a significant part of it treated with some of the vein treatments we can offer. So venous ulceration, often in the gator distribution of the legs. They're large, they can be larger and shallower than some of the other ulcers you'll see, like some of the arterial ulcers. And they, sometimes the patients will present with actually fairly little pain with them. And, given the appearance, you're often surprised. But here we have just a few examples of some of the patients with with ulcerations, the typical treatments is the local management. The real important issue is that with these patients, even with aggressive management that can heal up to 80% of them, 70% will recur within a year. So when you get to these ulcerations, they really do need their underlying treatment, because even if they do heal, they're going to be dealing with a recurrent problem. We talked a little bit about hemorrhage. Here's some of the information on the different trauma and emergency medicine journals that have described that. Atrophy blanche is just an interesting appearance where you have some scarring associated with the inflammatory process. So in the past, we've managed veins with conservative therapy, which is the elevation, the compression, and here we see the correct compression stocking where it's from the thigh to the toe, and here we have the knee high, which actually can lead to increased distension of the gradus afferens vein. But many of these patients have gone on themselves to get treated by dermatologists or plastic surgeons, where they go in and they just inject the veins. The problem with this is you're working on the downstream resulting veins rather than at the source. And we have kind of, here we have some slides just going over some of the drawbacks and the advantages of sclerotherapy. Phlebectomy came about it's been around for decades, but it was more popular in the 90s because patients didn't really want to have the full surgical stripping that involved being in the hospital and being out of commission for a couple of weeks. So phlebectomy was where we were locally removing veins. So this was sort of 90s, and you got some good visual improvements. But again, if you didn't get that trunk reflux, you were set up for these things recurring. Surgical stripping was the standard up until about 2000, 2005, and here it involved making incisions and pulling these veins out. The problem with that was that in addition to pulling that vein out, you would often have little nerves that were damaged and little branches that would be avulsed. So it really wasn't a delicate procedure. In about 2000 or 2001, actually it was 1998 for endovenous radiofrequency ablation, which uses thermal electrical energy, and then EVLT, which is laser energy, was 2001. These catheter-based techniques came about, where we can run a catheter inside the vein up to where the refluxing problem starts. We do local anesthesia and then pull the catheter back and seal that vein in place. So that way the blood that was refluxing into those dilated veins no longer does so, and the veins downstream will come down in size. This is just an example here of the radiofrequency version. So EVLT, we eliminate the source of reflux. It's a good alternative to surgical ligation. Often when patients come in, we do the full workup where we evaluate their legs with ultrasound. We go over all their history, and we come up with a treatment plan. The ultrasound is really what is the basis for coming up with the plan. We determine which trunks need to be treated with the endovenous laser. And then the residual, we actually will treat with sclerotherapy. Once you've taken all the most significant pressure off with the laser, then it's easy enough to treat with sclerotherapy. So here is after the treatment, we dress the patients with compression bandage, avoid some gym workouts for counter analgesia to their routine. Follow them up at a week with ultrasound, close that needs. And then additional treatment as needed. The ambulatory phlebectomy patients with very large veins after we've done the endovenous laser treatment. I'm going to finish off with just some examples of what look like after EVLT, weeks after EVLT, that's pretty significantly. How much improvement there is even in just from the endovenous laser treatment. And this is the complete treatment with sclerotherapy, times ambulatory phlebectomy is needed. So before and afters, compressing the reflux pathway, and sometimes have very significant look, but more importantly, pressure downstream, which leads to all of that we discussed earlier. So advantages, doing it in the office, outpatient, patients are right back to their routine. The ultrasound helps us determine what exactly is the problem, because there are different pathways sometimes that are leaking that you otherwise wouldn't be able to tell just by looking at the patient. Ultrasound helps us in doing the procedure, assessing access points, and determining which patients need a different approach. Here we have reflux from those pelvic veins we talked about, where the greater saphenous vein actually was normal, and there was no reason to actually treat the greater saphenous vein in this patient. So our plan here with these patients is we start from the highest to lowest point of reflux. We treat all the incompetent tributaries, and that way we can get the most comprehensive treatment, and at the same time, the least invasive approach. Here's our ultrasound follow-up, which shows greater saphenous vein, what happens to it after the procedure is thrombosed. 6 months to a year out, the body resorbs it, and you no longer will find it. Ultrasound is helpful for patients who have any recurrence, or if they have further symptoms, looking for different sources of reflux, or at that point, and helping us decide to refer them for more imaging, for example, the CT venogram of the pelvis. This is just a little brochure here, what we give our patients, what it looks like when you're having the procedure. That's me with our technologist and our nurse during the procedure, and one of our technologists scanning one of the patients. So in conclusion, varicose veins can be a sign of serious underlying pathology. Understanding the anatomy and variants is critical if you're involved in the treatment of varicose veins. And ultrasound really is the fundamental diagnostic modality for understanding each individual's anatomy and guiding individual treatment plans. And I think is why we've seen so many of the interventional radiologists around the country getting involved in varicose vein treatments, because we always read the ultrasounds and understood the anatomy, and then we just applied the techniques we use in other procedures in the hospital that we're very familiar with in terms of gaining access and vascular treatment, and combine that in the office to provide a really elegant way of treating sometimes very significant disease. Anybody has any need for additional information or would like to reach me at the office, I have the number here, and I'll open it up to questions.
Dr. Antonacci, thank you so much for giving us this informative presentation. So to everyone on the line, if you have any questions, I know we're just a few minutes past 1 p.m., but we'll go ahead and give it another question or two if you guys have any. Feel free to enter them into the chat box feature, or if you would like to ask your question live, feel free to click on raise your hand and I will unmute you for your question. A follow-up email will be sent after this webinar, which will include a recording of this webinar, as well as some additional resources on vein disease and how we can treat your patients at Charlotte Radiology. So if you have any questions, please go ahead and enter them into the chat box feature now.
Dr. Antonacci, I have a question.
Sure.
I was looking at the symptoms, the 6 symptoms that you presented. With your primary care providers, a lot of their patients are presenting with, if not all 6, some of the 6. When should they refer those patients to the vein?
So that's a great question. I have some patients that are referred very early on, some patients later on. I think if you're trying some of the conservative treatments like compression therapy, that's very easy to do in the office. And what I do is actually the lowest prescription strength that's acceptable for insurance companies, 20 millimeters to 30 millimeters. So I will put patients in compression stockings. If they're responding to the compression stockings, that's usually because it's improving either their superficial or deep venous insufficiency or both. So if you try that, even as your own clinical trial, see, the insurance companies make us do that for 3 months, often 6 weeks to 3 months, depending on the insurance company. So patients come in and see us, and we'll have our hands tied for 6 weeks to 3 months in these patients where we can't treat, even though it's clear vein disease. So if you're prescribing those stockings, and if you need prescription pads or you have any questions about how to do that, I'd be happy to help you, because those patients that come in from centers where they've had compression stockings, they've tried it, they've had really good success, that makes it, helps you in your decision tree there. They have these symptoms, you wear the stockings, they do great, There must be something underlying it. Let's get it checked out. But now they're already in the process of their conservative therapy, so it facilitates their treatments if they do head down that way. And there's criteria we use in the office for when they meet criteria to treat in terms of size of veins and amount of reflux. So even if you err on the side of having them come in and see us just to have us tell them, your reflux is mild, keep wearing the stockings. If it progresses, we'll consider treatments. That's fine. I think I'd rather err on the side of getting them in sooner to see us than later when they already have lipodermatosclerosis. Because lipodermatosclerosis or swelling, usually happens over years. So there's definitely different points in your interaction with the patients where you could get them in to see us and get them treated before it progresses even further.
Thank you. And I have an additional question. I know you said those individuals with a BMI over 45, you're diabetics, should they routinely come because of their underlying factors? And the second part of that question is, after we treat that patient, how often do they need to come back?
So that's a great question. I think if they're coming in with exercise intolerance, swelling, and even though you're not seeing veins, it's worth it to evaluate, because until you put the ultrasound down, you don't know, I don't know. So I think having a lower threshold with the obese patients that are presenting with symptoms is probably the better way to go. And then we can counsel them back and forth in terms of working on weight loss to improve the outcomes of their vein treatments. There have been a few studies out there that said, patients have a BMI of 45, maybe you shouldn't be treating those patients. So it's important we work together, identify the patients, maybe work on weight loss regimens, try to get their BMIs a little bit under 45 just to improve the potential for success. But then you have the other side where their BMI is 46, 47, 50, and they already have ulcers. Well, then your hands are tied. We do the endovenous laser treatment because that will work. That's 98, 99% effective at least relieving some of the pressure. And we might hold off on the sclerotherapy until their BMI comes down to a more acceptable level. So I think that may, I think being more aggressive with some of the more obese patients is probably better in terms of getting them to proper treatment sooner and getting the whole plan in place. And your second part of the question was, remind me?
How often for that patient population, because we know that as those patients grow older, they're more susceptible. So that patient that you've seen maybe in their 40s that you got their legs together, but they still have those underlying diseases, should they come back periodically, or how should the doctors address that?
So once we've treated all of the reflux pathways, they don't develop new ones. So if they have greater and lesser saphenous vein and there are no accessory veins and they're closed, and we do sclerotherapy, usually those patients, they by that point are pretty sophisticated. They've been through the treatment plans. They can say, my calves are aching, I'm getting a little more swelling. We'll rescan them. At that point, there's usually not a lot left for us to do. We'll rescan them anyway. It doesn't necessarily have to be a year. It could be 2 years, 3 years. We don't have a set regimen. We just say, well, come back if you as needed for symptoms. If your swelling returns, if you're having more inflammation, if you have another episode of thrombophlebitis, and we'll address those. It's more of a touch-up procedure. But if they're progressing after our treatments, then there's usually an underlying problem. That's when you'll see us. Sometimes the patients come to see us directly, and we'll refer them back to the office and say, hey, it might be time for an echocardiogram. It might be time to evaluate for central venous obstruction, in the pelvis, because once the superficial pathways are treated, we have to look at if there are, the other potential etiologies, and if there are not, those are the patients then we would put on compression stockings, ongoing, lifelong, to address, their leftover symptoms. But they can be challenging patients. I think our patients, we always encourage them anytime they have any issues to come back and see us. We don't have them specifically on a yearly or biannual or follow-up plan.
Thank you.
Thank you, Travis. Thank you, Dr. Antonacci. Thank you, Dr. Antonacci, so much for giving us this presentation today. Extremely informative. And to all who are on the line, if you have any additional questions that come to mind at any point, please respond to me in the follow-up email. I'm happy to pass your questions over along to Dr. Antonacci so that way he can connect with you to get those answered. So thank you again to everyone who joined us for the webinar for today's webinar on varicose veins, more than just a cosmetic problem. And I hope you all have a wonderful afternoon. Thank you.
Thank you.
Thank you.